So starting from the top, so in the imaging side, several things have come to light over the last, I would say, 1 to 2 years. Perhaps most importantly, and maybe the most worrisome finding, is that when one measures the brain size and brain growth of children with multiple sclerosis, we see that even from as early as we can measure it, brain size is reduced. So children already have smaller brain sizes and even skull sizes compared to age and sex matched healthy children, suggesting that something has probably been happening for some time, even before that first attack, and even if they're only 5. Thereafter, what I think is compelling is that the rate of brain growth is slower than what it should be for a child. Our patients do not reach maximum brain volume, so they never reach the top that they should. And then by mid-teenage years, we see actual brain atrophy. So even before someone hits their adult years, there's already brain volume loss in children with MS. This correlates to a certain extent with cognitive impairment. So about a third of my patients have cognitive impairment, and there is a relationship between cognitive impairment and brain volume, and even more, a stronger relationship between cognitive performance and thalamic volume. So this suggests that while traditionally we've thought about multiple sclerosis as a disease with an inflammatory beginning and a degenerative second half, pediatric patients indicate that maybe some of that degenerative biology is present as early as we can measure it, which then really emphasizes the need for prevention of degeneration, strong control of the inflammatory response, and neuroprotection. So that's, I think, a fairly important set of findings, and actually is informative to the MS field as a whole. It's not just what's relevant for children, although clearly that's our priority as child neurologists, but the fact that brain degeneration might start very early in MS is a compelling piece of evidence that's relevant to adult MS as well. So we've also looked at functional imaging, so looking at how the brain activates during a task. And what's interesting is that in children with multiple sclerosis, they show increased brain activation in key areas when performing certain tasks compared to healthy age-matched children. And this suggests that for everything they're doing, their brain is working maybe just a little harder. Potentially, that might correlate with some of the fatigue they describe, and certainly it might correlate with the struggles they have in school, particularly with multitasking and acquiring multiple rapid pieces of clinical information at once. Having said that, the majority of children, even those with cognitive impairment, are still achieving well in school. They're still doing a lot of the things that healthy teenagers would be doing. And so the message isn't all negative. My patients look well. If you saw them come in to chat with you, they look like healthy average teenagers. And physical disability is not an early component of pediatric multiple sclerosis. So the patients that I look after are doing well physically. Second speaker, Dr. Hemingway from the United Kingdom, is going to talk, as I said, about MOG-related disease. And the story about MOG started probably in the early 2000s, but really only in the last few years have the assays developed to a point where one can start to distinguish groups of patients more reliably. The assays have matured and are perhaps now more specific. That being said, there are children who come in with a first attack of demyelination that have MOG antibodies, and they really almost at this point appear to divide into two groups. One group of children in whom the antibodies are just one of many antibodies that are present when they're acutely ill, and that response appears to diminish over time, and many, if not most of those children have a single attack, and it is clearly not multiple sclerosis. It's not multiple. And then there are a group of patients that have relapsing disease that have persistent MOG antibodies, and these children can look fairly similar to children with neuromyelitis optica, which is also an antibody-associated disease to aquaporin 4. And so while we're not yet fully able to describe the pathogenesis of MOG antibodies, we haven't proven that they directly harm the brain. We certainly have a hint that the presence of MOG antibodies may dictate a different clinical course, and the treatments that people are using for MOG antibody patients appear to differ from the treatments we're using in multiple sclerosis. Certainly interferons and glutathione acetate don't appear to work in those children. So a lot more to be learned, but an evolving story that's very relevant to pediatric patients. And then finally, as I said, Dr. Chitnis is going to speak to us about the clinical trial landscape. As many people know, all of the therapies that are approved for multiple sclerosis in adults have undergone, phase 1, sometimes certainly phase 2, and then rigorous phase 3 studies with hundreds, if not thousands, of patients. Well, pediatric MS is a rare disease, happily, and so we are not able to have 300 or 400 children in each study arm because there aren't enough patients to do that. So the design of pediatric studies is something that's an area of active discussion worldwide. But at the same point, we really want to have the highest level of evidence for treatment benefit in children and certainly always treatment safety. So it's exciting to see clinical trials coming forward for pediatric MS. There have been challenges in enrollment. It's very different to enroll a child in a clinical trial compared to an adult. The parents have to miss work. The treatment protocols and the study protocols often require multiple visits, multiple imaging time points, and of course strict adherence to the study protocol. Well, that's not easy for working parents, and so when they're facing all of those challenges, not all families can do this. So that's proven challenging. And of course, some of the studies are either placebo-controlled or studies where there's a comparator arm and the comparator arm is an injection. So that's not always all that appealing to families. So we've certainly learned a lot in the last couple of years about how to do the first pediatric MS trials, and I think the next set of studies will be informed on what we've learned about the challenges of doing pediatric MS clinical trials. With that, I think we're also getting into an era with the now, I think, 15 or 16 approved therapies for relapsing, remitting multiple sclerosis, where we have a very real possibility of suppressing the majority of clinical relapses in relapsing remitting disease in both children and adults, which is a very different landscape than when we started looking after children formally, at least in our center, in 1999, where the entire treatment literature at that time was a single case report. And now we're looking at really informed information on how to best care for our patients, and that information is coming from both these clinical trials and then from an international collaborative network that communicate regularly in terms of informing each other on how we're all looking after our patients.